I've been for the past 23 years now. I also have an appointment as a core faculty member and courtesy appointment in biomedical informatics and medical education. So we're going to start with everyone. I'm going to ask each of the panelists to introduce themselves and also provide their own version of what is health informatics to them, in case there are some people in the audience who are interested in that kind of basic perspective. I'll kick it off by saying, from my perspective, health informatics is this intersection of the people, the technology, and health. My own research has very much focused on the people side of things, particularly patients or everyday people who are trying to manage their health. And my research has focused on ways for us to understand the challenges that they have and then to design new technologies to help them manage their health the way they would like to. My research has also focused on those people who have been marginalized by the healthcare system and particularly trying to support them. So now I'm going to go to Ari and see if you can introduce yourself.
Thanks, Wanda. And thanks, Kristen, for the introduction. And thanks to everybody for joining us today. I'm really honored to be here. My name is Ari Pollock, and I am a pediatric nephrologist. So I take care of kids with kidney disease. I'm an associate professor in the Department of Pediatrics in the School of Medicine, and also have adjunct appointments at the Information School and Biomedical Informatics and Medical Education. I've been doing this kind of informally and formally ever since I've graduated medical school, which was back in 2002. So it's been a while now. I'm actually a graduate of the information school. I completed the Master's of Science in Information Management back in 2014, and now actually do research in health informatics. My definition of health informatics, initially, I think I was more focused on that intersection of technology and health. But as I learned more about information science and methods, I realized that it's more about looking at the transition or translation of data into information and ultimately knowledge. And so I think of health informatics as the tools that allow us to capture data, whether that's clinical results or patient results or patient outcomes or other aspects of data that helps to inform decision making, and then how do we wrap it and present it to the people that need to use the data and use the information that stems from that data to ultimately make decisions, whether it's about their own health or decisions for others as a clinician or through public health. And so that's how I view and think about or define, I should say, health informatics. And that really informs my own research, which is looking at how we can help people make better clinical decisions. And I look at developing tools that support physician clinical decision making, and also developing tools that help patient decision making, and have mostly focused over the last few years on supporting my own patients with chronic or youth with chronic kidney disease and supporting their decision making process. Thanks again for letting me join today.
Thanks, Ari. Let's go on to Peter.
Thanks very much, Wanda. I think my point of view on this panel is going to be providing sort of a longitudinal and organizational point of view. So I've been involved in computer science and biomedical informatics for over 40 years, practiced clinically as a neonatologist for 20 years, overlapping with that. And I'm professor and chair of the Department of Biomedical Informatics and Medical Education. I have a joint appointment in pediatrics neonatology and an adjunct in computer science. I've been at UW now 32 years, hard to believe. And from an organizational point of view, in addition to serving as the chair, I also serve as UW Medicine's Chief Data Officer and Interim Chief Research Information Officer, and as a deputy editor for the Methods Journal of Biomedical Informatics. My research focuses abstractly on the integration of disparate data for discovery and applications. And I've done this in the area of translational bioinformatics, both discovering new genomic disease associations as well as creating knowledge bases for practitioners to apply that knowledge. Have done similar both foundational methodologic and applied work in clinical research informatics or support of clinical researchers, clinical trials, clinical informatics, the domain focused on care of patients and supporting healthcare providers, and some population health work as well. And then from an organizational point of view, the department is the home for a number of informatics programs, including a transcriptable option joint with the information school at the undergraduate level, a couple of master's programs, one applied, one foundational, and then PhD postdoc and clinical informatics fellowship training. So that's the perspective I bring to this. My definition of biomedical informatics, so for many years, it's been defined as sort of data, knowledge, and information in biomedicine, and specifically the use of data, knowledge, and information to improve health. And it's not just data, knowledge, and information, as Wanda and Ari have alluded to. People and organizational issues or people factors, human factors are a critical part of this as well. And so the methods tend to in informatics tend to focus on data, knowledge, information, human computer interaction, drawing upon things like information science, computer science, mathematics, decision theory. And then the applications draw more upon, for basic research, the biomedical sciences, for translational and clinical, and the clinical sciences. And then the entire domain of consumer health informatics sits at a really interesting intersection that Ari and Wanda have talked about. And then there's also the whole population and public health aspect, as well as the application domains within biomedical and health informatics writ broad. The health piece of it perhaps narrows down to the consumer and clinical part of it. But really, as I'll talk about later, I think they're all entwined.
Thanks, Peter. Let's go on to Cedric.
Thanks, Wanda. And thank you everyone for having me here. I'm very excited to be here. So I'm Cedric. I am an iSchool undergrad alum from 2019. And currently I'm a product designer at Coinbase. But before Coinbase, I was at a healthcare startup in San Francisco called Forward Health. They're insurance free primary care provider. And there I worked on about a year-long project called the Care Pods, which was sort of a micro clinic that was aimed to increase accessibility to healthcare, as well as provide self-serve procedures in these micro clinics. And I think my around my definition of health informatics, I think my focus really was around how people interact with their health data. And so exploring multiple mediums in which they can do that through physical devices, as well as like digital therapeutics, and as well as education too. Trying to teach people the basics about their health and empower them with the knowledge to develop their own perspectives and plan for their health.
Great, thank you. Let's hand it over to Lucy now, our final panelist, to introduce herself.
Yeah, thank you. Really great to join you all here. My name's Lucy Liu Wong. I'm an assistant professor in the information school at UW. I have adjunct appointments in computer science and engineering, human-centered design and engineering, as well as biomedical informatics and medical education. I'm also a part-time research scientist at the Allen Institute for AI. My work intersects with a lot of the other folks on this panel. So I'm focused on designing and building these language technologies to help make information more accessible to people, and specifically very interested in health and health-related information, and how to improve people's understanding and discovery of that information, and then also kind of increase their health literacy. So kind of back to the original question, seeding this discussion of what is health informatics. I think almost everyone's covered the various facets of it. But in my mind, it is this sort of data or information-centric these information-centric solutions for improving health and people's experiences of health and healthcare. I think something that's sort of interesting to consider is, so I really I started out as more of a methods person, thinking about how to like develop models or improve processes and things like that. But I do think that there's the human element is incredibly important in health informatics. So how are people's expertises being distilled into these methods? How are people's experiences shaping the design of these technologies? And then also the inverse, which is how are these data information technologies shaping the people involved in healthcare and in managing their own health? I think those are all kind of big questions that health informatics tries to contend with.
Great. Thank you, Lucy, and everyone for the introductions. I'm going to go on with some questions for the panelists. From your perspective, how has practical health informatics evolved over the past decade? I think Ari was going to kick us off for this.
Oh, yeah, great. So I'm going to kind of think about it from my perspective as first as a clinician, actually. And so I would say, I think the biggest changes really came about with the pandemic and the COVID pandemic and the changes with really forcing everybody to utilize telemedicine and the tools and practices that came with that. As well as the Information Cures Act, which was a law that looked at primarily looked at or incorporated this idea of limiting blocking of information, whereas before the information contained within the electronic health record was often available, but it was really hard to get it, whether it required asking for it from the health information management teams or it being delayed to patients and individuals because it had to be interpreted first through the eyes of a physician. All those things changed during the pandemic, and I really see that as being a huge difference in how information tools and technology changed the way I practice medicine. And so from a telemedicine standpoint, I personally I do a lot of my practice is in Eastern Washington, and so now I'm able to see patients without them having to travel to Seattle. Also, I'm able to see where they live. I'm able to see into their homes and be able to see aspects that were previously not available to me that I think allow me to connect with my patients in new and much more meaningful ways. And I think that's really allowed me from an information perspective to be a better and empathetic clinician. And then thinking more about how patients have access to information within the electronic medical record through tools like MyChart or other patient access portals. It used to be that results were delayed 72 hours before patients could see that information, and now they're basically instantaneously available once they're resulted. And now I see my colleagues when they're writing notes, they're adding addendums to the notes that basically say these notes are I support your right to read my note, but recognize that I'm using language that is intended for clinicians and not necessarily patients, but if you have questions about that, please reach out to me. And we're advancing things so quickly that people don't really know how to respond or how to adapt to this. And I think it's really interesting. Personally, I actually found having access to my own notes, clinical notes, really interesting. I had an interaction with the physician and read something in a note that they hadn't communicated to me, and I actually found it really important and meaningful to me, and that data was never shared to me through my clinician. And so I can just imagine how valuable it is for my own patients, because again, there's so much data. It's just how do we package it and present it to people? And now with the Information Cures Act, people can do it on their own time, at their own pace, on their own schedule, and utilize other tools like looking up information through web searches or whatever to help them better understand that information. So that's my that's what I see has changed so much over the past decade.
Thanks, Ari. I couldn't agree more. As someone who works a lot with everyday people and trying to manage their health, these changes have been dramatic and in a very positive way for most people. Peter, did you have some things to add from your
Yeah,
perspective?
what I would say is that's a really good example of how more than over the past decade, but really accelerating over the past decade, we've moved from really siloing of these different data collections to integrating them. So early on, as consumer health evolved as a specialty, there was a good decade of effort on your personal health record where you would try to type in, or as Ari outlined, download into this personal health record your data, but you didn't have access to the raw data. To where now patient portals are ubiquitous and the ability to download information from those patient portals is ubiquitous. And those patient portals are a shared resource between the provider team, so nurses, nurse practitioners, physicians, respiratory therapists, et cetera, and the patient. And this has been true within the other domains as well. So in the last decade, what had been occurring in the research arena, the use of multimodal data, so genomic data, high throughput data, biologic data, integrated with clinical data, integrated with population data, environmental data, exposure data, has really exploded. And though COVID was not per se a driver, I think COVID really illustrates this, where the public was aware of the fact that we were genotyping COVID strains and that different strains had different clinical impacts and different patients had different strains. And that was both biological data, but also integrated into the medical record. A lot of places were using patient-reported symptoms to track and understand the evolution of the disease. So patient-reported outcome data was integrated into the medical record, integrated into research repositories, and the barrier between clinical care and public health and population health broke down as people started to realize that it's not just what the patient has or what their family has, but what their neighborhood has, their city has, etc. And so the full potential of multimodal data across all these application domains in biomedical informatics, I think, really became very, very illustrative. And then all of this data was used for a large amount of mathematical modeling by the UW's own Institute for Health Metrics and Evaluation, again, which wouldn't have been possible if you had everything siloed. So I think that is both a change over the next decade and something we're going to see a lot of moving forward as we integrate different streams of data together to inform how to best care for ourselves and for our patients.
Right. Thanks, Peter. Cedric, I think we'd be interested in your perspective from the, tech startup world and that side of things.
Yeah, definitely. Just as Peter and Ari were touching on with the digitization of medical health records and the increased access to more and more data, there has been all kinds of growing consumer interests in consuming that data as well. But there's been a lot of ways in which different startups and companies have been trying to focus on different facets of that data. And there's been multiple niches within the industry that are quickly growing, getting a lot of venture capital funding and just explosive growth. Spaces like the longevity area, companies like NIA and Levels that does like biomarker tracking, companies that explore your VO2 health, DEXA scans, gut microbiomes. All of these niches follow the same trend of providing deep insights into one's own personal health and for them to hyper optimize their own health and performance. And so as data becomes more and more consumable and easier to process, I think it'll be a matter of how do we translate that and communicate that to patients, and how do we do it in a way that gives them valuable insights into their own health and lets them take actionable steps on a day-to-day basis.
Great. I'm going to shift to be more like forward looking and talking about what emerging technologies do you see as most promising for advancing health informatics? I'll start with Lucy.
Yeah, I mean, I think a lot of these practical directions that were mentioned by other folks here are um, they're still, emerging and changing. But I think the thing that's on the top of everyone's mind is the emerging kind of generative AI technologies and what they can do for healthcare and pretty much every other industry. But I think in healthcare in particular, there are promises and a lot of challenges to applying these technologies. So, I'll start with positives, where I think that these large language model technologies, these Gen AI technologies, are really capable and good at addressing problems around access to information. So this has come up already. I think a couple of the other panelists, like Cedric mentioned, that your company kind of worked on this. So we know that health information is there's not it's a little bit technical. It can require expertise, and then now with all these like disparate data streams coming in, sometimes we need another layer in which to interpret that information and figure out what's important. So I think these technologies do have this potential to help support patients in understanding health information or searching for health information when providers are not available. So filling in this gap in access. And one of the things I think about is I conducted a study with some other researchers and with the Association of American Medical Colleges, speaking to mothers, like mothers with newborns or kind of people in maternal health. And we gave them access to an AI chatbot, had them interact with it and asked, hey, like, would this be useful for you? Is this the type of information that you had access to? And there were some really interesting responses, right? People found that these chatbots were a safe place to ask questions, especially stigmatizing questions, and that it would have been nice to have them in the middle of the nights when nobody else was available. So I just think that this kind of 24/7 access to technology is a really powerful thing for these models. Yeah.
Thanks, Lucy. I'll open it up to anyone else who would like to respond to that, or we can go on to the next part.
Yeah, no, I'd love to respond to it. So I think, first of all, I think it's worth putting, again, I said I would bring the longitudinal perspective. So depending on who you talk to and how you count it, this is the fourth or fifth golden age of AI in health, in the 50 years that people have been looking at this. And I think Lucy, you've really nicely outlined some of the opportunities, and Cedric as well, with all of this data available out there. The perspective from the longitudinal point of view is, as you start looking at these data sets, which have high dimensionality and relatively low number of samples, that are non-deterministic, meaning they're probabilistic and predictive. You have to be really careful about whether a given observation, whether you make it from analyzing your data or whether it's a large language model or an advanced machine learning network with convolutional neural nets, whether it's causal, associative, or occurring by chance because of the fact you've got too many dimensions and not enough observations to really reconcile those dimensions. So I think that's both the opportunity and the challenge in all of these spaces. And one of the things that I was asked to talk about briefly was this notion of decision support technologies, because I think the gold standard here is whether the system performs better than our current state of the art. So, Lucy, right now, the current state of the art at 3 in the morning is nothing, right? And, I had a colleague who called me last night because of a question, and there was nobody else to talk to, and a chatbot would have been far better than nobody. I was probably better than the chatbot, but still, the point being, when the gold standard is terrible, then a 95% accurate large language model AI system is fantastic. The question is, though, if the current state of the art is 97 or 98 or 99% accurate, then do you want to put in a system that performs less well? So that's an enormous opportunity and challenge for all of these machine learning and generative AI systems. And I think, the key things that we do in addition as healthcare providers, in addition to the emotional pieces of healthcare, the providing support, moral support, helping people through a difficult time, is trying to figure out what's going on, diagnosis, and trying to figure out what to do about what's going on, namely therapy. And there are, for those providers who are able to make diagnoses and prescribe therapies, like advanced nurse practitioners, doctorates of nursing practice, psychologists, doctorate psychologists, physical therapists, physicians, they all are ultimately liable for whatever goes on. That's the current state of the art. So if the AI system makes a mistake, it is the provider who is liable. And so the FDA, after a good decade of discussion, finally has regulations and guidance around simple rule-based decision support systems, what has to be approved by the FDA, what doesn't. But generative AI, I think, has enormous potential. But since it took a decade to figure out simple if A, then B type regulation, it's going to take a while to figure out this regulatory space. And I think it's going to be really important for all of us working in this space, whether it's you in the audience, those on the panel, providers, patients, to just be aware of this and make sure that people are looking carefully at how these systems are functioning against the best we were able to do without these systems. So that would be my thought on the emerging technology. So very much in the AI, big data, data science, machine learning space. But as Lucy and Ari and Wanda have talked about, and I alluded to as well with there's more to it than just diagnosis and therapy. There's this whole human aspect that can be supported and mediated by technology as well.
I'll just add, building off that and kind of getting back to your siloing of information that you mentioned earlier, Peter. I think the next important step is, now within a healthcare system, you're probably breaking down silos and stuff like that. But now we really need to break down silos between healthcare systems. And when I, review grants for the NIH and looking at, someone who's developing the next algorithm for machine learning to diagnose something or to help with clinical decision support, they're almost always based on the data that's contained within their own institution. And so really, I think the next step is how are we going to really facilitate that data sharing across institutions, across potentially even countries or starting cities, states, even bigger than that. And that's how we're going to be able to overcome some of the challenges that you mentioned initially, Peter, in your response there about making sure that we're not just making decisions or recommending decisions based on chance, but we're finding true patterns that are real across a variety of different populations, and that we're not going to be introducing bias into these decisions based on the limited samples that we have access to within our own individual institutions.
Yeah, these are all really key points, and I want to kind of add a thought here. I think data sharing is really critical because that's the only way that we can validate the models and also kind of make sure that they're generalizable across institutions. So I think, Ari, your point there is super important. But I wonder if there's maybe also a potential for these AI technologies to help in generating better synthetic data for testing and evaluation of these methods. So instead of relying on these small samples from our local hospitals, being able to replicate data across lots of clinics, but not in a way that undermines the privacy and security of the data that these models are being trained on. Of course, this could backfire as well, right? Because we know with synthetic data, there's this additional layer of validation where we just never quite sure if it holds on to the same kind of second or third or fourth order relationships that are present in the original data. But I still think it's an exciting possibility.
Great, thanks. I think we've covered a variety of very interesting ways that things are moving forward. Next, I want to talk about how you see health informatics improving patient engagement and empowerment. And because this is core to my area, I'm going to take moderator's privilege and kick us off, particularly in a direction that I think we haven't talked about much, and that is people supporting each other. Part of my work has always been encouraging what we call peer support. So people who've been through cancer, helping other people who have been through cancer. And now I've been shifting more to people who have challenges in getting adequate healthcare from healthcare systems. And in particular, in the current political climate, we have people who are transgender or gender questioning, particularly youth, who are now forbidden from being able to seek a lot of care officially from healthcare institutions, particularly in certain states. And yet there are they have certainly needs to understand their feelings and what's happening to them and to connect to others. And I do see that health informatics has a role to play in that, whether it's from the official telemedicine opportunities from places like Seattle Children's that does support things like gender affirming care, to people having social media connections to each other, to TikTok and other ways for them to connect with each other and understand what's happening to them and deeply share each other's personal expertise in health. So I see that as a very exciting direction as well. Ari, maybe you would be interested in talking some about your work with children in this space too.
Yeah, sure. Thanks, Wanda. And thanks for kicking off the discussion here. And I'll just qualify this as that I get to collaborate with Wanda a lot and on some of this work. And and I think, as a pediatrician, it really is fundamental to kind of who I am and how I deliver care to my patients. And I really think about my job as a pediatrician is really to help children experience their childhood in a way that they're best able to and grow up to become adults. And part of that process is learning how to be um, learning how to manage your own health conditions. And it's a key aspect of any pediatric in any child, I guess, who is growing up and needs to manage their health. And it's more important for those with a chronic disease like chronic kidney disease. And so I really kind of pivoted over the last 7 years or so, trying to understand how can we really support youth with a chronic illness and really leverage informatics tools to empower them so that they're able to engage in a more meaningful way with their clinicians. And really, to me, one of the most important ways where we can do this is by eliciting and capturing patient values and patient priorities and being able to empower youth to communicate that with those around them, whether it's their caregivers, their parents, their clinicians. And actually now working on a project where we are actively trying to understand how we can do this to support decision making for youth with chronic kidney disease and really leveraging information tools to help youth do this. And I think one of the most interesting ways and um, I think interesting opportunities is by helping youth tell their story, their individual stories, and learning how that we can collect these stories, communicate these stories to those around them who are involved in collaborating with their healthcare. Stories can be told verbally, stories can be captured in pictures or photographs, stories can be prompted from individuals. And I think what's really interesting is how we can leverage our information tools and our electronic health record to try to capture these patient stories, which I think can be really powerful to help patients understand their own priorities, to help them reflect on how they've grown and developed their own self-efficacy and agency as they become more skilled with managing their diseases or just their growth in general, being able to generate empathy with their clinicians. And I found it a really, really powerful tool. And so I look at how we can develop or generate these tools or these kind of, I guess, segments of information to really help advance pediatric patients or children as they grow up and become independent youth who are going to ultimately be responsible for taking care of themselves, which is such an important part of pediatrics.
Thanks, Ari. Yeah, good way to start off life and a good skill to learn for the rest of your life. Lucy, I think you have also done some interesting work in this space, particularly on ways to, improve access to and understanding of health information.
I'm going to go ahead and say that Wanda, you and Ari are the experts on patient engagement and empowerment, but I'd say the work that I've done is mostly more on that earlier phase of kind of understanding of information. And I do think there's been a lot of methodological improvements in that space. So in the clinical note, what's important for the patient to know, what's just jargon or kind of documentation artifacts. If a treatment has a certain success rate, how do we actually interpret that in the context of a patient? So I think that my experiences here are really regarding that. And then, but I do think of understanding as this kind of like a fundamental step towards some of the work that you're more engaged in. So I think there's work in your lab that more talks about how patient empowerment can lead to better kind of quality of care through almost like a kind of a patient self QA type role that people can play, and just having more people, giving people more agency and kind of control over their care, I think is understanding is a really vital component to that. Yeah.
Thanks, Lucy.
Mhm.
Anyone else wants to chime in, or we can go ahead to the next one?
I forgot to mention one thing, and Lucy, you reminded me as you were talking about like how do you design a note that is accessible and interpretable and useful for patients. And it really just reminded me of something that I learned when I was getting my MSIM degree, was just the importance of user-centered design and really truly understanding the needs of individuals, and really trying to design technology with everybody who's partaking in that technology together. And I think a lot of times in the past, we've created tools for people that haven't worked because we haven't asked them what they truly need. We as designers haven't been empathetic to understand how to do that. And so I think, and that's something that's been so important to me in my own research and my own work within informatics, is truly engaging the users who to ask them what they need, how can we do this better, and how can we create whatever it is we're working on, and in a way that will truly helps them achieve their goals and reduce the problems that they're experiencing.
Great, I couldn't agree more, Ari, and I might even add, and in some cases, working with those people to help design what will help them best. So next I want to go on to talk about how can health informatics professionals balance the need for accessibility to data, which we've all talked about is so important and critical for people managing their own health. How do you balance that against the need for privacy and safety and security to make sure that bad actors don't get in that information? And maybe Cedric can kick this off from a
Yeah.
industry perspective.
Yeah, definitely. I think this is an intersection that Ford definitely had to work through on multiple occasions. And because our big goal for our care pods was to increase accessibility to care. And so deploying these micro clinics where people could walk up to it, go in and do a self-serve blood draw or health scan, or maybe use a Bluetooth stethoscope to listen to their heart and gauge if they have signs of gallops or murmurs. These were the uh, procedures and applications that we aspire to build for people to give them access to do on their own time and need. but they're also uh, very uh, private actions to take. And so if someone is in their space and they're trying to get their blood drawn, or maybe they need to disrobe, um, how do we had to figure out how to make users feel safe and like they had a private space that people weren't going to walk in the middle of these procedures, and that if they had any emergency situations, that there was always a one step action to uh, alert local authorities, or call any ambulance in case something happens. Um, Now we did deploy these microclinics with uh, MAs inside of them, so it wouldn't be like a typical doctor's office where you have the full staff, doctors, MAs, all the clinicians, but it would be at least one human presence, and so that was how we ensured at least some level of uh, human intervention if needed. But we also made sure to uh, create a very clear locking mechanism on the just entire experience of entering into this micro clinic and leaving. By having that locking system accessible to the user and very clear and obvious, it hopefully gives them a sense of control over their space and knowing that no one's going to be getting in. And then also in terms of their uh, access to their data and safety and security of their data, we made sure to really drive home the fact that we were keeping this data within our ecosystem, um, and that it was going from these care pods to their mobile phone, and it was only going to be seen by our forward doctors. But a lot of these, as you know, Ari was talking about, as Lucy was talking about, um, these are experiential um, details that we really had to be mindful of when designing this experience, especially since there really wasn't this didn't exist before. And so we're defining something truly from 0 to 1. And we had to keep these values in mind as we were developing this care pod, and make sure that these values carried through the whole experience from end to end.
Others would like to talk about this issue? Balancing accessibility with privacy and
I can add one thing, and again, wearing my hat as a pediatrician and pediatric informatician, there's two things that kind of come to mind. One really focused on pediatrics. Again, it's that transition to youth and this whole idea of what information can be shared with youth and their parents, especially as they are becoming adults and starting to make adult related decisions, like decisions around their sexual health and mental health. And there's laws that protect youth who are seeking care in those areas, and that information is really is meant to be and leak and it is private between their caregiver and themselves, and it is not information that can be shared with their parents. And that creates challenges, right? So how do you limit access to those aspects of their care, but still provide access to other elements of their health care, which their parents or legal guardians are legally entitled to as their caregiver? And for a while there, the answer was simply to just turn off access to everything for youth aged 13 to 18, because there wasn't a simple way or an easy way to filter out what was okay to give to youth for topic A, but not for topic B. And I will say, fortunately, at least at Seattle Children's, we have figured out ways to get to solve this problem and now actually allow youth, or have made it so that youth and their caregivers can get access to their medical record, and not just have a big kind of have that aspect turned off. But now physicians or clinicians can actually enter in safe parts of the EHR, which are protected and not distributed to or is not made available to everybody on the topics of sexual health or mental health. And I think it's just an example of how sometimes it takes time. Getting back to, Peter before, is like it takes time to figure out how to do this. And while, a lot of times we think about the 80% rule, this will work for 80% of the time, but it doesn't work for 20% of the time, or maybe it's even 95% or 99% of the time, but that 5% or 1% is actually meaningful. And I think we do need to start working on how do we to solve making sure that our tools aren't kind of interfering in those areas.
Really excellent point, Ari. As a parent of a kid with chronic illness, it was very frustrating to me when my kid hit that space, and I lost all access, and they lost all access for a while. So those are very important things to consider. Peter, I see you had some things to contribute to.
Yeah, I mean, I hate to bring up our polarized national political landscape, but this has some important implications. I'll bring up three different areas, so where there are different views in this country about what's okay, what's not okay, what can be reimbursed for, and what's not reimbursed for. And so abortion, illicit use of drugs, and transgender patients. And in those three arenas, those all obviously have important medical import. And as someone crosses state boundaries, there is a need to have an integral medical record to deliver appropriate care. Yet at the same time, with different laws around drugs and around transgender care, around abortions in different states, this is starting to create some significant challenges in how do you preserve the privacy and safety of individuals and the integrity of their medical care without exposing them to potential legal or other liability as they cross state boundaries. And we've had a lot of experience with this in the Washington, Wyoming, Alaska, Montana, Idaho area, because the University of Washington School of Medicine has practice sites in all of those arenas, has medical school training sites in all of those arenas, and has to navigate these conflicting state laws. And so that's creating a really interesting question of like, well, on the one hand, for using abortion as an example, if someone had an abortion, that is very relevant information because some symptoms they're experiencing could be a complication of that abortion when they go back home to the state where the abortion is illegal and they've had an abortion in a state where it is illegal. Yet at the same time, sharing that medical record information could expose them and their providers to legal liability in the state where it's illegal. And so these are some things that the entire health information exchange community is really wrestling with, simply at the level of exchanging data for patient care, let alone trying to exchange data to make sense out of data across organizations.
Thank you, Peter. I think that was a very important point to bring up, and you brought it up in a very eloquent, salient way. I think certainly affects too many people today. I'm going to transition now to our last question from the panel, for the panel that we've pre-created, and then we'll switch to questions that I see coming in from others. I want you to respond to what you think the next big breakthrough will be in health informatics. I know that's a hard question, but no one can predict the future. But what do you see things, or where do you maybe want things to be heading? Go ahead, Peter.
So again, looking at this long arc, I'm now going to talk about like the gold standard isn't necessarily gold. It may be bronze or maybe even pewter or something. Because, of the medical interventions we do, the therapies, not the diagnoses, only about 10 to 15% are really well supported by the evidence. About 50% of what we do is really not supported one way or another. So there's a big gap in our understanding of what goes on. And I think that this emerges from the fact that we as humans, as biological species, are non-deterministic, non-linear dynamic systems. And that means that small initial changes in condition can result in dramatically different outcomes. And this is really hard for us as humans to fully make sense out of. And what this means is our very act of labeling people as having a particular diagnosis and then determining what the treatment is on the basis of our label is not optimal, not ideal. And so what I'm really excited about is there's some emerging work in biostatistics and applied math that is looking at inferring causality and generating new knowledge out of the raw data. And I'll illustrate this with I think probably an easier example. It's not a cool modern example, but it's an old example. We used to have a disease called dropsy, and dropsy was when you got all puffy and you were really tired all the time and didn't have a lot of energy. And dropsy we would today call edema, but edema, so swelling of the tissues, can be related either to your inability to excrete fluid, which is a problem with your kidneys, or an inability to pump blood, which is a problem with your heart. And there's a treatment called foxglove, which is today digitalis, which was used, hundreds of years ago, which is moderately effective if your heart's failing, but will kill you because you accumulate doses of a toxic drug if your kidneys are failing. So some people with dropsy responded very nicely to foxglove. Other people dropped dead. And it took about 100 years, 150 years to disentangle those. But today with genetics, there are dozens and dozens of places where we have disentangled diseases that look the same but are fundamentally different. So diabetes is type 1 diabetes and type 2 diabetes are not two different diseases. They are probably hundreds of different diseases. And if we can begin to untangle some of this genomic, environmental, and co-occurring stuff through modern mathematical techniques, leveraging all the data we have in the patient record of care and disease, I think that's really exciting to generate new targeted knowledge for individual patients. So that's what I think is a really cool emerging opportunity.
I'm sold on that vision, or can we have that now, please? I think that this idea of like using these technologies to expand on, I guess you could maybe call this personalized medicine, or kind of integrating all of the individual data sources and kind of imputing any data that's missing to be very compelling. I think I'll add to that and kind of continuing on this data integration front. I think another really exciting potential breakthrough is also integrating patient-generated data into this milieu. So I feel like we've opened up the fire hose on a lot of sensor data, like kind of tracking data. But so far, it's been really impossible for clinicians to engage with that data because clinicians don't have more time. And we don't even really know how to construct a more holistic picture of a patient's kind of life and lifestyle outside of the clinical encounter from that data. But I think these kind of more modern technologies will reduce the barrier between those things as well. So coming up with a more synthesized picture of an individual.
Yeah, and I think exactly, and I think that that's a really good example of where, for example, the timing of exercise and the relationship of cardio to strength and sleep and all of that is clearly dependent, but we just don't have enough data points in prospective trials to figure it out. Yet, if you took 1 million patients who are wearing, their personal, whichever watch brand they preferred to monitor sleep and exercise, you absolutely could track that. And you could begin to, with that size data set, looking at those parameters, tease out time of day, genetic background, environmental exposure, things like that. So yeah, absolutely. The data I mean, everything in the medical record is the data we collect on the basis of what people who show up with a problem need to have collected,
Right.
right? So we don't have like sleep and exercise data on normal healthy people, and we don't have sleep and exercise data even on patients who are coming to us with a particular problem unless sleep and exercise relate to the problem they're seeing us for. So yeah, all the data outside the medical record is probably more important than data in it.
I'll just add to kind of continue on that path. I think those things are all really important. I would love to see us have a system where the patient really is in charge. The person really is the manager of all their health, and have the technology in place to support them in doing that in effective, good way. They are the ones who are most motivated to have good health. They are the ones that have or possibly have the most time to put into that if they had the right kind of support to process that information and understand how they connect to the studies and pull all of those kinds of things available to them. I think Cedric's work and the startup was going in that direction too. And I love to see the world heading in this space where people have a lot more of this ability to do their own blood tests and all of these kinds of things that to some people are a little alarming, but I'm hopeful that we will head in this direction, particularly with the shortage of clinicians and the challenges that clinicians face with managing the patient load that they have. Can there be a shift there? I think that could be interesting and possibly controversial as well.
Yeah, I'll just add, I love where Peter and Lucy took this, and I'll just say like the problem isn't a paucity of data. There's more data than we know what to do with. And I think you both, eloquently stated that. And I think, the challenge right now is we have a single health record, or there's a few different companies, but these companies present the data all in the same way. And and in whether it's a clinician accessing that data, if it's a patient accessing that data, if it's the data that they're generating at home, it all goes into the system that is constrained by how someone designed it or thought it should best be designed, based on what the state of the art was, probably almost going back 50 years. And really these systems designed really to support the economic needs of healthcare systems, not truly to take care of patients. And so what I would love to see in terms of a big breakthrough is where the systems actually kind of they become transparent, or they kind of disappear, and that you're not obligated to learn how to use them or figure out what you need from, where do you have to go to find this piece of information, where you actually have to know what you're looking for before you can actually find it. But our systems actually can prioritize and present the information to you based on the need at that time, or who you are, or where you're going, or actually, so it's almost like a precision medicine of the information system itself. It actually redesigns itself based on who you are, what your needs are, what information is available to you at that time. And I would love to see a system where you don't even see it. The system is totally invisible to you, but the information that you need for when you need it at the time you need it is presented to you and perfectly packaged. I think that's very lofty. I don't know, but I would love to see something like that in the future.
Just as an additional area of excitement, I think the points that the rest of the panelists spoke to are super exciting. And one other area that I guess I'll bring up that I have a personal bias towards because of my past work experience in 3D and mixed reality is the application of mixed reality towards the healthcare space. This is one that we've started to see take shape in surgical spaces, and where surgeons are using these headsets and devices to much better visualize their procedures and allow for even telerobotic surgical experiences. There are often times where multiple surgeons are working on the same patient because there's maybe a bit more of a niche situation that needs to be figured out. And so traditionally they'd be called in maybe via video call. And it was this kind of archaic experience where they would have to send information back and forth to be able to convey what's going on with the patient. But with mixed reality, it offers this new opportunity to bring those remote surgeons into the space and be able to actually see what's going on. And it creates this more immersive experience that I think you combine that with telerobotic medicine, and it can really lead to some really interesting improvements on the clinician side. Also, mixed reality and 3D can really help with the patient engagement and also education too. I think it can be really tough to communicate certain concepts to patients because of the nature of maybe the condition they have. Either it's too small for them to really comprehend, or the photos and imaging that we have of it today are not super high quality. Mixed reality offers another medium for us to educate patients, build their understanding, get their buy-in, and allow them to really understand what's going on with their bodies.
Excellent points. I hope all our visions will come true in the near future. I think these are all great points. I'm going to shift now to some of the questions that we've had from the people in the audience that Kristen has kindly shared with me. The first question is about this notion of information overload. Is there any research about the impact of information overload in the healthcare space and its impacts on patient outcomes? I'm thinking of the mass amount of information available in medical records now, and also the many, many touch points, the texts, the emails, the calls from pharmacies and clinics, etc.
I can take this because I've done a little bit of work in this area, actually. So actually there is data that looks at the negative impact of information overload on patient outcomes. And I think it across a variety of different domains, but one is just looking at the cognitive demand with searching for information within the electronic health record and missing key information and making mistakes based on this fire hose of data. I think there's definitely evidence to support that. And I think the other area where there's a lot of evidence focusing on kind of how electronic health records are designed and how clinicians interact with them is looking at burnout, which is a big problem in healthcare right now, especially with clinicians. And there's a lot of evidence that has tied electronic health record design and burnout, and that whether it's looking at information retrieval or information entry, looking at how long clinicians spend documenting information outside of clinic hours, all negatively impacts the kind of, or it contributes to burnout, I should say. And I think there's also high correlation between physician burnout and patient outcomes. When we see higher levels of physician burnout, we see worse patient outcomes. And so I do think it is a big problem, and I think we need better ways to address it.
That's a great point, Ari. It brings out, some of the things that Lucy talked about of wanting to bring in all of this other data, but it's a challenge when people are already overloaded. Anyone else want to add to that? Okay, our next question. Oh, go ahead, Peter. Oops, you're muted.
Sorry. This is a really good illustration of where if you could discover new causal patterns in the data, then you could use those causal patterns and surface those patterns. So LLMs can do some of this. So people are using LLMs to do summarization of charts to flag and highlight important data. My concern, though, is they're based on essentially statistical patterns in the data. So it's the most plausible thing that it surfaces, which has about a 5% error rate. And as a physician, that makes me kind of a little queasy that there's a 5% error rate in my summarization of the chart. On the other hand, as the questioner has inferred, there is so much data that you can't, that the physicians and the nurses and the psychologists and everybody else's summarization rate, error rate is probably more than 5%, but we don't really know what that is and can't prove it. So, but I would feel more comfortable with sort of knowledge-based driven summarization, not purely sort of pattern-driven association through LLMs. But I think there's definitely opportunities for summarization of clinically significant patterns out of the chart that are particularly ones that are hard to catch by a human.
Quick Quick thing to add to this, I think on the other end of information overload and kind of using models to help summarize is also alert fatigue, which also has negative relationships with patient outcome. So oftentimes, like when we want to identify like high risk patients or kind of build a model that to predict an outcome for a patient. We just kind of add that as a additional layer on top of the EHR, which doesn't really account for the user's experience in engaging with that tool or kind of building up a mental model of that tool. So I think that's the other side of this, where if we also included a lot of automated tools into the EHR to help reduce information overload. We also have to be mindful of how those tools are designed and how they impact clinician workflows.
Excellent points, everyone. I'm going to shift to our next question, which was, what are some introductory level jobs you're familiar with in the field of health informatics? I'm thinking Cedric and Peter, but I could
Yeah, I mean,
have some too, but yeah.
so because biomedical and health informatics is about data knowledge and information, I think iSchool graduates are uniquely well positioned because you're well versed and immersed in these areas. And those are concepts that in health informatics are more relevant than the computing concepts of a database or a program or an algorithm. And the human side, which is also part of the iSchool curriculum, is really critical. So I think a priori, folks with an iSchool background are going to be really competitive for the types of positions in hospital systems and in electronic health record vendor companies and in the types of startup companies, Cedric, that you were part of, where you're going to have a physician or a nurse or a respiratory therapist or a physical therapist or all of the above advising on the clinical patient, et cetera, side of things, but you need someone who understands data knowledge, information, people's interacting with information, and how to design optimal systems. So, Cedric, I think coming from this background, your description of all the work you did and the nuances and all of that is a perfect example of how someone without a health informatics training got a lot of on-the-job training and brought a lot to that area. And so look at the types of companies that are working in this space and then look for what kind of jobs there are, because a lot of those jobs are not per se health, but are data knowledge and information. A lot of health stuff can get acquired. And since this is alumni, I'm not going to say that you should, if you're really interested, then I'll plug the health informatics transcriptable option. But for those, for anybody who's in the program now, that is an option. But seriously, if you look, you will find tons and tons of positions that they're not looking for a programmer, they're not looking for a DBA, they're not looking for a database person, they're looking for someone to sit as the mortar in between various people, developers and physicians and providers and patients and all of that. So I think there are a lot of opportunities. UW Medicine has 500 or 600 employees in the health IT space, and I would say a good 10% of those positions are entry level, and I think iSchool graduates would be really well suited to that. Same thing at the major health record vendors, the major, the groups at Apple, Amazon, Google, et cetera, are working in the health space, all need people, not just with the technical background, but that ability to bridge the technology and the tools and the people using them to make a difference.
I don't think I can say much better than Peter, but I'll just add on, like, personally, I've had friends who also came from the info undergrad program who went on to work in health tech spaces in their respective capacities, whether it's engineering, design, product, data science. I have some friends who joined labs who that do public health studies, and they work in more of a data science and analysis capacity. That's a really common one, and they went into that straight out of undergrad. So I think there are definitely a lot of entry-level roles that exist that will allow you to work directly on health tech and health informatics. It just depends what capacity you want to do that in.
Great, thanks. Our next question is that healthcare informatics sits at the intersection of technology, healthcare, and policy. What are 2 to 3 top barriers to collaboration between these disciplines, and can we potentially overcome them? I think we saw this in COVID for sure. People want to talk about that as well.
Maybe I can start. I think this is a really difficult question. In any kind of interdisciplinary fields, the role of the person at the center, this like interperson disciplinary person, I see it as a lot of kind of education across the various parties. So you kind of have to speak all the languages and teach other people how like what's important in the other domain and what's valued. I think at least that aspect doesn't differ too much for health informatics in particular. I have not engaged directly with policymakers, but I feel like most of my work sits between kind of computer scientists and healthcare providers. And that is also a very, it can be a really funny space, right? Like as a computer scientist, sometimes we need the data to be in the same format. We need to be able to, we need a substantial enough data set. We need annotations. And it's very difficult sometimes to communicate to the clinicians why we need those things because they feel extremely irrelevant to the clinician. And then on the other side, I think, for example, if we are developing like an outcome prediction model or risk prediction model for use in clinic, sometimes the machine learning person or the computer scientist is so focused on making the model better or like improving the metrics without understanding what those metrics actually imply when applied to patients in the clinic. So like what exactly is your 90% precision? Does that actually result in better care seen by patients? So there's a lot of this like disciplinary misunderstanding that can happen if there's not someone who's there to kind of communicate to all sides like what is the importance of this aspect of the work. Not sure if that addressed the question, but I'll have the other panelists sort of add. Yeah.
I think those are great points, Lucy, and certainly things I've experienced too. I'll add for the policy side of how important that is. Actually, even to enable some of this collaboration. Like I'm thinking in the times of COVID, there were regulations that got in the way of this collaboration. Things like telemedicine was restricted to within state. And you could only care for your patients if they were in the same state you were in. That was, as a policy and regulation decision, that was relaxed in COVID to try and help deal with the emergent situation. Unfortunately, it's been put back in place now, but I think those are the kinds of things that really can make a big difference on us being able to make advances and collaborate together and connect. That's one example from my perspective.
Yeah, from my perspective, I agree with everything you said about the technology in healthcare, that particular collaboration, interdisciplinary collaboration. I would say sort of policy, I'd broaden it to sort of the societal point of view. I would say there are two competing barriers here that are sort of diametrically opposed. One is really radical innovation takes significant investment of resources and has a high potential of failure, which has historically been the purview of either federally funded or corporately funded research. But we're working in the health space, and Wanda, you eloquently made the case for, patients controlling their own health and well-being, et cetera. But unfortunately, we have a system that is, I think we have now the dubious distinction of being the worst healthcare outcomes of the developed countries, yet we invest the largest per capita in that. And that is fundamentally a policy issue. And where this becomes a barrier is that means it's as a consequence of a very unequal distribution of healthcare resources to different people who have different access to the healthcare resources. And all of the things we're talking about are predicated upon the someone investing the money to pay for the development and maintenance and deployment of these systems to provide better care, but all of that requires someone to pay for it. And right now, with the way, I'm not advocating for any one particular solution, but I'm simply saying objectively the current healthcare system is seriously broken. And in order to fix the healthcare system and technology, absolutely, technology, health informatics, the human computer interface side, the people side, the patient side are all part of this. But we're still going to be suffering from very poor healthcare outcomes unless we have some policy changes around how healthcare is financed and more equitably provided to the people in this country. And I'm saying this country because we're living in this country, but and this is where we have particularly bad challenges. So that's not an informatics policy, it's a healthcare policy, but I think it's really underpins a lot of this stuff. I mean, like preventive healthcare has been shown over and over and over again to be really, really effective, but there's no profit margin in preventive healthcare. Therefore, preventive healthcare isn't funded. Therefore, we invest in, the Ozempics of the world at enormous cost rather than trying to engage patients, as you suggested, Wanda, in their own improvement, their own management and accountability of their health, and trying to figure out again, there are some patients for whom Ozempic is the only solution, but there's others where there may be much less costly solutions preventing the things that are triggering the glucose resistance in the first place.
Excellent points. I'm going to transition to our last question, which was, do you have experience with or thoughts about using health informatics for population health management? For example, Healthy Planet. I'll just start by saying there is a program at UW and population health initiative program that the University of Washington has started, trying to look at some of these kinds of issues. And so there's been an investment at the university level to try and fuel more collaborative efforts to look at these population level health issues. I see Ari is unmuted too.
Well, thanks for bringing that up, Wanda. And I think it really kind of goes back to the last question is really, it's a lot of the intersection between these three areas that makes population health successful or not successful, because it really requires, it's truly policy-based, it's truly technology-based, and it's prioritized, it's looking at what populations or things need to be prioritized and resourced and stuff like that. So it really kind of goes back to a lot of the previous discussion. A little bit more kind of practical, I will say, we do have experience with it at Children's. We do have a lot of different registries for looking at a specific populations. So in my own field, we have a registry looking at kind of a rare disease, something called nephrotic syndrome, which is getting back to Peter's description of edema. I'd actually never heard that phrase before, Peter. Was it DOPS? Is that what you said?
Dropsy, DROPSY.
Dropsy, yeah. Anyway, so we have the database that we manage is a population of children with this condition called nephrotic syndrome, which is lots of different reasons why people can have this. But we are part of a collaborative working with other pediatric nephrology groups across the country, which are designed to improve outcomes for children with this condition. And one of the things that we've learned is that making sure these kids get their vaccines and on time really helps to improve outcomes. And so we use the Healthy Planet Registry within our division. Our nurses are actively managing it, looking to see which patients are coming to be seen in clinic, which patients have not received their vaccines, and leveraging that. This is a great example of where they actually have to go to the state of Washington's vaccine registry to kind of coordinate that data. But they identify patient or kids who have not had the appropriate vaccines, and they say, hey, you're seeing this kid in clinic. Can you tell them that they should get this vaccine? Because if they get this vaccine, their likelihood of getting an infection from a common bacteria that is very lethal will be dramatically reduced. And so that's just one example within our own practice of how we do this. And there's lots and lots of other examples within children's that manages these kind of at-risk populations to try to minimize these bad outcomes. But you can imagine how this would scale to a diabetes clinic or a heart failure clinic, where these small improvements or changes or interventions could have huge societal and population benefits.
Thanks, Ari. Excellent point. I mean, it goes back to the other question about collaboration. To really do effective population health requires so much collaboration, not just our spaces of technology and people and information and health, but also the environment, climate, so many other aspects that affect population health too. Well, I think we're coming to a close now, and it has been a great pleasure to work with this great group of people on our panel tonight, and having some great questions from the audience to spark these interesting discussions. I've certainly learned some from my colleagues as well. And so thank you all for coming. I don't know if Kristen, if you have some things you want to say as well.
I first want to start by thanking our wonderful panelists today, Lucy, Cedric, Peter, Ari, and our amazing moderator, Wanda. Thank you all. You have provided such insight to something I think I mentioned offhand once or twice, that I didn't have quite the background in health informatics when I started this, but I'm so happy that we got to spend this last hour together and learn more about what is happening in the health informatics field. And I want to thank everyone else for joining us tonight. This has been a really great panel, and I want to invite you all to some of our future events that are coming up. This month, we are keeping it pretty quiet, but you are welcome to nominate an alum, a fellow alum, or yourself for one of our Alumni Impact Awards. We also have MOS, which is our MSIM Online Student Summit keynote, happening on 2/21. We have a library alumni, iSchool Connect, which is a networking night for all of our library alums, happening on the 26th of February. And finally, iSchool's first ever Family Day at UW Women's Basketball will happen on March 2nd. We'll send along an email after this to send details on all of those things. But again, we're so happy to have you here with us tonight and hope to see you at a future iSchool alumni event. Have a great night.